The following is a video demonstrating an effective method for arthroscopic management of far medial hip capsular defects that consistently allows for reproducible capsular repair even in the absence of proximal capsular tissue. These are our disclosures. Preoperative MRI with a gadolinium arthrogram is of particular utility to analyze for capsular insufficiency, as it demonstrates both capsular volume as well as egress of contrast along the location of any present capsular defects. This image shows an arthrogram in which dye has extravasated from the capsule proximally up the psoas bursa, indicating a medial capsular defect communicating with the iliopsoas bursa itself. This is a contrast-enhanced MRI which further demonstrates the medial capsular deficiency that allows direct communication to the iliopsoas bursa with the iliopsoas marked by the red arrow. It is important to note the lack of a substantial cuff of proximal capsular tissue on the MRI. This is a common finding and highlights the inherent challenge of repair of chronic medial defects, particularly as it relates to reducing the distally present capsule to the acetabular rim. The patient is positioned supine on a lower extremity suspension table with a perineal post and the feet placed into padded boots. Following creation of standard anterolateral and mid-anterior portals, an interportal capsulotomy is made in the standard fashion. A diagnostic arthroscopy should then be performed. The iliopsoas tendon is often visualized through the medial capsular defect, and it is possible to drive the camera into this defect to visualize the entire distal tendon. Capsular adhesions are often present. Working percutaneously from the mid-anterior portal, a number 1 vicral suture is passed through the proximal capsular cuff using a 70-degree suture passer, and then subsequently retrieved and tensioned outside the body with a hemostat. This is then repeated posterolaterally, working percutaneously from the anterolateral portal to pass, retrieve, and suspend a second suture. Suspension in this manner provides excellent visualization of the acetabular rim for both subsequent central compartment work and placement of the anchor for medial capsular defect reduction and repair. After central compartment work is complete, preparation for closure of the far medial capsular defect can begin. While viewing from the anterolateral portal, a 2.3 mm double-loaded all-suture anchor is placed through the mid-anterior portal and deployed into the medial aspect of the anterior-inferior iliac spine. It is important to avoid placing the anchor lateral to the anterior-inferior iliac spine, as this can make reducing the distal medial capsule difficult. Following anchor placement, sutures are sequentially passed distally and sequentially lateral to medial along the medial capsular defect using a 70-degree suture passer. Traction is progressively decreased on the operative extremity to allow for safe, increasingly medial instrumentation between the capsule and femoral head. Each passed suture is employed to suspend and further reduce the distal capsular cuff towards the acetabulum. These sutures are then sequentially tied from medial to lateral. The medial capsular closure is inspected to ensure adequate repair, and then the remaining traction is released from the operative extremity. These still images demonstrate before and after tying the medial capsular repair sutures. After completion of the femoral osteochondroplasty, the interportal capsulotomy is inspected. If capsular redundancy or insufficiency is noted, it is recommended to perform capsulorrhaphy of the anterior capsule to prevent joint instability. Multiple suture tapes are passed through the acetabular cuff of the interportal capsulotomy with a 70-degree suture passer, and then retrieved through the distal cuff, tensioned, tied, and cut. Capsular closure is considered satisfactory when the femoral articular cartilage is no longer visible. Thank you for your time and attention.